Well, I have to say, guys, it's a bit of an intimidating prospect standing here this morning, having sat in the audience yesterday. And as some of you will know, I got more and more anxious as the day went on that I was actually going to be able to tell you anything new this morning. And so anxious, in fact, that I went back to the office and changed the presentation that I'm giving you. And even wanted to change it again last night. I thought, well, damn it, I'm sorry, guys. Here it is. But what I am going to try and do is, where I can, make the links between what I'm saying and what was said yesterday. And I hope that will be helpful for you and sit it into a bit of a sort of more theoretical, maybe, context. So, our hospitals. One thing that people didn't mention much yesterday is just how much communities love their hospitals. Just how difficult it is to actually change them, which certainly in this country has been a big, big issue in terms of moving forward and changing the configuration of services. And one comment that was made to me about this was that actually, certainly if you're sitting in an NHS, the hospital is probably one of the most visible signs of that NHS to you. You don't have a contract, you don't have an insurance document that you can say, I'm owed X, Y, and Z, but if you've got a visible hospital, it really means something to you. But this hospital, as we heard yesterday, is under significant pressure. In this country and across the globe, money is a significant issue for healthcare systems, as our spend on healthcare is outstripping the rate of growth in GDP. And we heard yesterday, in this country in particular, we've got issues around medical staffing. And Ian touched on those yesterday, but we have limited numbers of senior, or historically have had limited numbers of senior medical staff, and therefore have had a model reliant on junior doctors. And as those junior doctor numbers are not keeping pace with, well, they're actually going to be starting to decline, but also we know that junior doctors providing care is not as good as senior doctors. So all of that is creating pressures on our hospitals. And then you heard a lot yesterday about the issues around the changing pattern of disease, and something that perhaps didn't come out as strongly as it might have done yesterday, and I'm certainly going to be spending some time on the impact of new technologies. And as some speakers were alluding to yesterday, it really calls into question the role and function of the hospital. And so I'm going to spend the rest of my time trying to explore how those pressures are playing through on that role and function. So, as I'm sure you've heard these phrases lots of times before, hospitals built in an era of episodic care, and as Ian made a lot of play of yesterday, with a tradition of medical silos. So you go in with your very clear condition, you get treated, you go out again, and that's the end of the process. The problem is that actually people now have multiple comorbidities. And when I say multiple comorbidities, we are talking 7+. If you see the notes of an older person on a ward in an acute hospital, they are this thick. They are this thick with incredible numbers of different investigations, etc. The panoply of diseases that people can take in with them to hospital now is quite extraordinary. And that means that they're having huge numbers of medications that can interact with each other. And a big, big issue, which again, maybe it came out in some of the side discussions, not in the big plenary, but the role that dementia is now playing, the challenge that that poses in terms of treating people, for me, is a massive issue. The hospital where I'm a non-executive director, 40% of our inpatients have got dementia. That is a huge caring challenge. And these people need continuity of care, and as far as possible, care in their own home. The hospital is not proving to be a very good place to treat that type of patient. However, while they need care closer to home, ideally in their home, there are things that are driving us to centralise services and take hospital services away from that population. And one of those is the role that medical advance is playing. It is extraordinary the degree to which we now can treat people and treat people in highly sophisticated ways. So somebody's genetic makeup is going to determine which drugs they should be given in the future. The way in which we can use interventional radiology to guide and make surgery ever more specific and sophisticated. But that means that you need people who have very high degrees of specialised knowledge, and that sits in real tension with the other factors that I was talking about. They do, however, offer the prospect of yet more opportunities to keep people alive for longer. And that, of course, then drives us to that scenario of people living longer, but with multiple conditions potentially. And as I was alluding to earlier, there's a significant issue in this country particularly, but I know it's true in the States too, that consultant-delivered care is what we need. And there are differences in outcomes between patients treated at nights and weekends, unacceptable differences in outcomes. And if you need a critical mass of consultants to deliver care, then that requires some degree of centralisation. And as I say, that is a problem for us. People talked about the ageing population yesterday, but the scale and rate at which our population is ageing is really quite extraordinary. And again, I remember at the end of the day yesterday, people were calling into question, do we need more or less beds? Well, one of the big challenges for us with that ageing population is it is those older people who use our beds. The rate of difference in use of beds by age is again very, very significant. And one of the things that you will know when you go on to an inpatient ward is it mainly is full of very frail, older, vulnerable people. Here we have some of the examples too of the rate of growth of chronic disease. It isn't just an issue now, it's a growing issue. And a number of things I'd want to draw out from this for you. First of all, let's look at diabetes. Diabetes is a classic marker disease of lifestyle problems. That statistic alone is enough to argue for the importance that people were playing on yesterday of an environment that supports fitness and well-being. That is an incredible time bomb in our population, because once you have diabetes, you are much more at risk of heart disease, of stroke, a whole panoply of things come with that. And so that is why prevention is incredibly important. The problem we face is that we have this in our population now. This burden of disease is not going to go away. So if we think that we can get rid of hospitals in the future, we have a significant population that are going to need care. And one of the reasons that we need care too is actually that I'm sad to say that as we grow old, our bodies do just start to fall apart. And musculoskeletal disorders, things like being vulnerable to fractures, yes, being fit and active can help with this, but it doesn't totally prevent it. So I think we do need to be cautious if we think that we're actually going to be able to sort of eliminate the need for medical care in some sort of hospital-like setting. The other statistic which underlines that is cancer. And while there are some few cancers where we're actually starting to get an opportunity to give people a vaccine against them, in the main, they're not. And so people, while they are being treated and live having had cancer, once you've had cancer, I'm afraid, your likelihood of using healthcare services goes up significantly. So again, we have a population here who are going to be needing medical care and support. So what we've got is on one side a set of forces which is driving the centralisation of care, and on another sets of forces which were equally powerfully saying, no, we need local access to care. So how do we reconcile these two forces? And for me, there are two key factors at play here. One is clinical networks and the way in which we can link smaller hospitals to more centralised hospitals, and I'll talk a bit more about that. And the other critical thing is information technologies and new ways of working. And that will facilitate dialogue between clinical staff in a way that we haven't really seen the full of. And I would really underline the point that David was making yesterday, that I don't think any of us really comprehend the scale of impact that IT is going to have on healthcare services in the future. What we don't know is what the relative net economic benefits are of either centralisation or decentralisation. And I'm afraid I've thought it felt as like quite a lonely rearguard action against massive arguments for centralisation, because the evidence just isn't there to support it. So I think you need a both and. So here's an example of a centralisation of services, something that has happened in London very successfully. So if you have major trauma, you need a really good constellation of specialist services to come together all at the same time. You will need vascular services, high-end diagnostics, specialist surgery. That cannot be provided in all places at all times. So what's happened in London is a few places have been designated as major trauma centres where that constellation of services are, and other centres, other hospitals, then act as a referral point onto that. Ideally, the ambulance will take somebody straight there, and in the main they will. But if they take somebody to a local hospital who then feels that they can't manage them, the protocols are driving the people who need the care into the major trauma centre. Once they've had that specialist care, they can then go back for rehabilitation, back to the local setting. And that model, that sort of tiered approach to care, is something that we're seeing increasingly in all sorts of different services, and is something that is a really key feature, I think, going forward. And we've got this tiered model in Northumbria. Ian referenced this yesterday. So in Northumbria, they've resolved those tensions that I've been describing, the need to deliver consultant, deliver care, the constellation of services that you need for a really good emergency surgery service. And they've centralised that all in a big emergency hospital, a new emergency hospital, interestingly. It's going to be interesting to see how this works out economically. And then they have given local services that are less, for less severe cases, retained them in their local hospitals over quite large distances. So it will be really interesting, as Ian says, to see how this model works out in practice. Yeah, watch this space. And that's, I thought, as architects in the room, is a picture of the building, but many of you may be aware of that. Has anyone in here been involved in the Northumbria project? No. Then this is another example of how we get a networked-based approach, but in stroke using telemedicine. And so what we've got here is that we've got the specialists are able to be remote from the place where somebody needs to be figured out, how should I manage this patient? Because if you have stroke, a key question is, should I be giving you thrombolysis? And there's only a very particular window and very specific set of clinical conditions that say, yes, you should be getting thrombolysis. If you do, and you're in that window and you're an appropriate patient, that can have a huge impact on your outcomes. And what London did in solution to this problem was that it, like trauma, it centralised it. So we've got hyperacute stroke units, and it's getting all the patients who need that hyperacute care into that central service. But other places where geographical distances are more challenging have used this telemedicine model, so they're able to put the digital image out to the specialist who looks at it, and then in consultation with the local clinician said, yes, give thrombolysis or not. And another example of how we're managing to sort of bridge this central local dimension is through eICU. And this is a really interesting one. So in ICU, you need very high levels of specialist care, both nursing and medical care. People are very, very sick in an ICU setting, as I need hardly tell you. And so you need people round the clock to be monitoring patients so they can react very quickly if somebody starts to go off. And so what you do in the EICU model is you've got that central team able to deliver care 24/7, but they're monitoring people remotely. So they are able then to relate to the local team and say, actually, hang on guys, something's going off here, you need to do X. They can do a whole load of things remotely that historically would have required somebody in the room. This is completely changing the face of healthcare. It allows us to think very, very differently about how we configure services in the future. And the brilliant news about this particular model is the evidence is showing that it improves outcomes and reduces costs. So this telehealth piece of healthcare, for my money, is going to be a really, really significant part of health in the future. And the other brilliant thing about it is it creates a support mechanism for clinicians from people who've got that specialist care and expertise. A big challenge that certainly we've got in this country in our general practice is GPs now are expected to be, if you're managing this constellation of patients with lots of chronic disease, you need to have a degree of sort of specialist expertise in all those chronic diseases, which is very hard for GPs, and particularly given GP training in the past has not necessarily covered all of that. So this provides a mechanism for GPs to have a link to specialists and to be able then to get some advice about how to manage patients. And you get something that is a mutually reinforcing scenario. The traditional model of GPs referring someone into a specialist and then getting them back again doesn't enhance GP learning at all, as my work on referral management told me quite strongly. So I think this is something really to watch for the future. And the other thing that I wanted to talk about was actually in our hospitals, there are going to be a whole load of new opportunities that technology is going to bring about making them more efficient and use resources more effectively. We've got on the bottom left here, South Glasgow, which is a wonderful big centralised hospital deploying porter robots in its settings, and I think we heard robots being mentioned yesterday. But we've also got the RIFID technologies being able to track things in our hospitals and people, medicines, patients, and that will enable us to manage and make flow hugely better than it has historically been. One thing that I'm sort of really conscious of in many hospitals, hospitals are flying blind to the management of resource within that hospital, and this gives you a whole new way of relating to that. And we'd heard yesterday, I think the example was given of the iPod and its impact. The real impact there was the digitization of musical information. We are about to embark on the digitization, the comprehensive digitization of clinical information, and that is going to revolutionize healthcare. It's going to enable us to be hugely more understanding of the impact that what we do to patients has. It's going to be absolutely massive in my view, and it's going to enable us to look at patients across the spectrum. We'll be able to integrate social care records with healthcare records, community care records, mental health records, to see people in the whole in the way that we historically haven't been. One of the things that I find extraordinary sitting in a hospital as a NED is patients are just activity. We are desperately trying to engage with patients in a much more meaningful way as a hospital, but we don't see their whole pathway of care. We don't see the ex-GP appointments that it's taken before they got to us, or the poor social care that happens after they leave us. But in a technology-enabled world, that will start to become very visible to the system. The system should start to see the impact that it is having on patients, and hopefully will learn from it to become a truly learning organisation, something that IHI has been espousing for a long, long time, but actually I think the technology is going to enable us to do it in a way we haven't historically been able to do. But I didn't want to leave hospitals without absolutely underlining the therapeutic impact that the design has on patients and us, staff. I mean, actually, when I was at the King's Fund, as many of you will know, the King's Fund hosted Enhancing the Healing Environment. And one of the things that I really took from the discussions with staff that worked on that programme was the impact that the environment has on staff as much as patients. Staff, after all, are there 365 days a year experiencing that environment. And their morale in the future, I think, is something we really, really need to take hold of. So that environment is key, and it's also key in the context of those changing patient needs that I was talking about, patients with dementia. I watch patients at Kingston completely disorientated, not knowing which way is up. We've got a big programme there now to try and redecorate our wards and get them more patient-friendly. But I think until you've really been exposed to dementia, you do not understand the degree of confusion that abounds in somebody who's got a demented mind. So I just wanted to pick up this example, which now sort of takes us, so we've seen some of these big centralised, glossy, South Glasgow, Northumbria, big hospitals of the future. But other hospitals, smaller hospitals, are starting to reconceptualise themselves as hospitals that will be close to their communities, really bringing on board the links to social care, links to primary care, and indeed actually the voluntary sector, which for my money is another big thing that is changing, is the role that the voluntary sector plays in healthcare in particular. And indeed volunteers at Kingston, a huge part of our sort of workforce now are volunteers who are fabulous. They really bring a really positive contribution to the trust, and one of the things that I hadn't really expected, but they actually act as great advocates for patients. They are, they will not stand for poor hospital food in a way that our older, frail patients might be a lot more tolerant. And Yeovil is taking forward designing its future with its local community through the sort of data analysis I was talking about. So they have linked their health and social care data and their primary and secondary care data to really look at what it is that their population needs. And they have shown the huge driver that this multimorbidity is in terms of hospital use. And I use this slide, which is now staggeringly out of date, but shows how prescient Susan was in her earlier life, because this is her work when she was working with the Nuffield Trust then. But I think all of the things on that slide absolutely resonate with what we heard yesterday. So she's picked up the relationship with the environment, a sustainable. I mean, my goodness, I took away from yesterday those messages about sustainability. I think they are absolutely critical. This new relationship with the community that hospitals or community setting is serving, but also the high-tech possibilities, the way in which we can get hospitals to relate differently to people. And so we've now got, I talked about the specialist to generalist sort of link with telemedicine, but of course it's absolutely true too for the possible link between specialists and patients. We are being able to take care into patients' home, and America's got much more experience of this than we have, partly because the distances are so much greater, but they absolutely facilitate a new way of relating to patients that means that people do not necessarily have to trek up to the outpatients department and sit there and wait forever and a day. And it also gives new ways of relating to patients about managing their own conditions and supporting self-care. So when I went to the US and saw one of these in action, there was a really interesting dialogue that I heard between the nurse and somebody at home, just really exploring, had you taken your diuretic medication? Well, maybe you should do this. A totally different way of being able to relate to somebody rather than, sat in front of a consultant and a big outpatient desk between them. And so potentially we have this very, very high-tech world with data whizzing around all over the place, allowing us to be this very, very intelligent system. And I think there are some real possibilities there. The one thing that I would add at this point is something that was pointed out to me by a GP who's very sort of stands up for the rights of patients. Not everyone wants to be in that world. Not everyone wants to be submitting their health data every day. That can feel a bit like 1984. So I think we just need to bear that in mind always when we're looking at these things. They don't all have a sort of a rightness to them. For some people, they will be absolutely fabulous, but maybe not for all. And so we mustn't lose sight of, and again this came through yesterday really strongly, what really matters to people. And the Joseph Rowntree Foundation, who in this country do some fabulous work supporting people who've got challenging needs, looked at what older people want. And what they said mattered to them were meaningful relationships. And of course, that's what we threaten when we take people in for stays in hospital, that then actually the trigger the move into residential or nursing care. So we absolutely need to watch out for how we can support those meaningful relationships. And of course, we need to recognise, and again, this came through from the discussions yesterday, that actually the hospital is just one end of a whole continuum of care. And actually, if you build an infrastructure around that, around supported living that enables people to be as independent as possible, then you will reduce that risk of the hospital being the piece that sends you home and that sends you into supported care away from the connections that are so important to you. So where does that leave us? I think in my view where that leaves us is that you need to recognise that hospitals are not islands. There was a tendency yesterday, I think, to sort of conceptualise of the hospital on its own. It is part of a very ever-growing interconnected web of care, a web of care that begins in the patient's home, runs through primary care, community care, mental health services, social care, and information technologies are going to be a way of binding that web of care and strengthening it in the future. And so I think we've got a really fabulous set of opportunities ahead of us to support patients and deliver fabulous hospitals. But we really must be mindful of the fact that they sit in this interdependent system. Thank you very much.